Hello, my name's Arif Khwaja. I'm a consultant nephrologist at the Sheffield Kidney Institute. Welcome to this second lecture on bone disease after kidney transplantation. And what I'm going to do in this lecture is focus on the management of bone disease after transplantation. So the key objectives of the lecture are hopefully to help you develop an approach to managing bone disease after transplantation. And then I want you to be aware of some of the key clinical trials concerning bone disease and kidney transplantation. Now, when we think about what happens to patients and what we're trying to do when we manage bone disease, what we're really trying to do is reduce fracture risk. Now, there are a number of different determinants of fracture risk. In the general population, as well as in the transplant population, bone density is a very important risk factor for fractures. And you can assess bone density using DEXA scans. And obviously there are a number of things that may impact on bone density. Age, female sex after the menopause, steroid exposure, total steroid use will reduce bone density. But there are a number of other, if you like, risk factors that determine the quality of the bone and therefore the risk of fracture. So for example, as well as bone density, we know people with kidney disease have abnormalities in their bone. So there's a qualitative problem with the bone. And that can be due to sort of pre-existing renal osteodystrophy. So they may have renal osteodystrophy or renal bone disease, whether it's adynamic bone disease, mixed bone disease, osteoitis, fibrosis cystica, high turnover bone disease. There's a whole spectrum of bone abnormalities that will contribute to causing the bone to having poorer quality. So levels of parathyroid hormone, levels of vitamin D, levels of calcium will all contribute to the development of osteodystrophy. Now, the only way you can assess bone quality is to do a bone biopsy, and that's not something that's done routinely in many centres. And of course there are other risk factors for fractures as well as the bone quality and the bone density. There are things like your general frailty. People who are more frail are more likely to fall. People who have drugs that are perhaps cause postural hypotension are again likely to increase the fracture risk. So it's very important when you think about what you're trying to do after transplantation. You're trying to reduce the risk of fractures, and therefore by managing bone density, for example, you're only targeting one of potential 3 or 4 different risk factors for fracture. And it's very important that you realise the limitations of any strategy that's purely targeted just at bone density. So we went through this briefly in the previous lecture, and I'll just go through it again. There are a number of mineral abnormalities that occur after transplantation. Initially there's hypocalcemia, and that's followed by hypercalcemia. That's associated with relatively increasing PTH, although PTH levels fall, but they may not fall to the appropriate levels for kidney function. And there may be also increased vitamin D production from the graft, again contributing to hypercalcemia. Hypophosphatemia increases the risk of osteomalacia, and that may be due to increased PTH as well as increased FGF23 secretion. And again, there's that can cause reduced osteoblastic activity. Patients may have low vitamin D levels after transplantation, and hyperparathyroidism, although it improves, it does persist in patients post-transplantation. Also, patients may get hypomagnesemia, and again, that may contribute to bone disease, but that's also another mineral abnormality recognised after transplantation as a result of CNI use. So what are the guidelines? How should we manage these mineral abnormalities? In essence, we should just manage them as in CKD. So what KDIGO says, quite reasonably, is measure the calcium phosphate at least weekly in the early post-transplant period, and thereafter measure it 6 to 12 monthly, or 3 to 6 monthly, or 1 to 3 monthly, depending on the degree of kidney function. So there's nothing necessarily surprising about that. That's something I'm sure we all do. And in terms of management, well, obviously if you're vitamin D deficient, so you first of all need to measure vitamin D, and if you're vitamin D deficient, you want to replace it. KDIGO recommends that we should measure bone mineral density with a DEXA scan if the GFRs greater than 30 and the patient's on steroids in the first 3 months after a transplant. You know that's a 2D recommendation, meaning there's a very poor evidence base in that. And the reason is that we don't really know whether, first of all, whether any interventions such as bisphosphonates will actually improve outcomes after transplantation in terms of fracture. So we might be able to identify low bone mineral density, but whether treating the bone mineral density will improve fracture outcomes, we don't know, partly because, as I said, as well as bone density, bone quality is going to impact on fractures and other risk factors for falls as well. And surprisingly, again, a 2D recommendation because there's no evidence, but it seems very reasonable. If you're vitamin D deficient or you do have evidence of low bone mineral density, then you should consider treatment with a bisphosphonate. Very sensibly, they recommend that you shouldn't do bone DEXA scans in CKD4 or 5, as bone mineral density doesn't predict fracture risk. But furthermore, there's nothing you can do. Bisphosphonates and denosumab, which is another agent that's used in osteoporosis, are basically contraindicated in CKD4 or 5, or if you are going to use them, you can only use them in conjunction with a bone biopsy. So there's very little evidence to support the use of these drugs in advanced kidney disease, whether in the native kidney or after transplantation. So there has been a lot of variable data sort of showing showing kind of variable outcomes as to whether DEXA predicts fracture risk. But this is quite a nice paper from Sweden. It looked at 238 patients who underwent DEXA between 1995 and 2007. 46 patients had 53 fractures, so roughly 19% of the population had fractures. And what you see is, if you look at the risk of fracture, you can see that if you have normal bone mineral density, the risk of fracture is relatively lower, relatively less than if you've got osteoporosis as compared to osteopenia. And so this is really the basis of any recommendation to do DEXA routinely, is really based on this data. Okay, so let's just talk now about some key clinical trials in bone disease after transplantation. First study I'm going to talk about here is the use of Perak Acetone to reduce parathyroid hormone post-transplantation. So this is an open label study published not very long ago, a year or so ago, and this looks at the effect of Perak Acetone on parathyroid hormone. And what you can see is that once you give people Perak Acetone, which is a vitamin D receptor agonist, you can see the PTH levels fall significantly lower in the treatment group here in the dashed line compared to the solid control group. So evidence that vitamin D lowers parathyroid hormone. Of course, that doesn't tell you whether vitamin D will reduce fracture risk, reduce pain. This is a much older study, which is from Holland, I think, and this was a sort of randomised controlled trial looking at the effects of calcium and vitamin D supplementation on bone loss post-transplantation, and patients were either received 1,000 milligrams of calcium plus 0.25 micrograms per day of vitamin D, or they didn't receive any treatment at all. And what you can see is that in the vitamin D and calcium group, in the pale bars here, there's significantly less change in bone mineral density at the lumbar spine, a big difference at the femoral neck, again a difference at the trochanter, and a non-significant difference at the water region. But generally, again, replacing calcium and vitamin D, or giving calcium and vitamin D post-transplantation, seems to reduce reduce bone loss, really, reduce the loss in bone mineral density at 6 months. Of course, what this study doesn't tell you is what happens at a year, where there may be some recovery in bone mineral density, and what it doesn't tell you is whether there's any impact on fractures. And if we look at all the studies of vitamin D and calcium supplement, which is sort of summarised nicely in this sort of relatively recent review, what you find is that most of the studies suggest that vitamin D combined with calcium does seem to attenuate bone loss in the first sort of 6 months to a year after transplantation. That's not always the case, but certainly most of the studies seem to imply that. So reasonable evidence that vitamin D and calcium will impact on a surrogate outcome, which is bone mineral density. So we've already said that parathyroid hormone is another problem, and hyperparathyroidism is another problem after transplantation. So what does cinacalcet do? Well, there are lots of very small studies you can see, small numbers of patients, 9s, 11s, 40, 50, which show that cinacalcet post-transplantation will reduce calcium, will reduce the serum PTH. Of course, by reducing the serum PTH, you will have less phosphaturia, so actually the serum phosphate is actually likely to increase rather than decrease. But again, what you see in all these kind of observational studies is that there's no real meaningful endpoint in any of them. Most of the endpoints are involved. No, sorry, that's not quite the right thing to say. All the endpoints tend to be biochemical endpoints, calcium, phosphate, PTH. There's one exception here in this study by Chu, which looked at bone mineral density, which suggested that there may be a difference in bone mineral density in the cinacalcet group, but that's a very small study. Okay, so a lot of work has been done on bisphosphonates after transplantation, because we know that bisphosphonates in the general population are licensed for osteoporosis and steroid-induced osteoporosis, and we know that reducing bone mineral density is a big problem after transplantation, and some of that is undoubtedly steroid-driven. So this is an early study, which is a randomised controlled trial looking at ibandronate being given at 369 times 0 months after the transplant. And if you look at bone mineral density in the lumbar spine and the femoral spine, what you see is there's a significant difference in bone loss with the ibandronate, that's in the circular, with the circles here and here, compared to the control. But remember, this was published in around 2001, when perhaps the steroid dose exposure was much higher than it is now. This is a more recent study published a few years ago now from the UK, from London and some centres around the country. And this was a study looking at pomidronate and its impact on bone mineral density after transplantation. So there's 93 patients in this randomised controlled trial. All subjects, interestingly, got calcium and cholecalciferol, and they got pomidronate at 3 monthly intervals for the first year, and then further treatment at 2 years. And what you found on the whole was that lumbar spine, or the hip, the wards area, and even the femoral neck, although it wasn't significant in the femoral neck, the bone mineral density was higher in that arm, in the arm that got pomidronate. Okay, and the fracture rate appeared to be lower as well. So the fracture rate was lower in the treatment group than in the control group. This is a more recent study, published a couple of years ago, and a very interesting study. So this was a double-blind, placebo-controlled study with 129 kidney transplants. And patients were given ibandronate 3 monthly for 12 months, and everybody got oral calcitriol and calcium, and including the placebo group. And what you can see is that both at the lumbar spine and at the femur, although ibandronate was associated with a higher, with an actual increase in bone mineral density, what you find is that the placebo, those randomised to placebos, those randomised to just calcitriol and calcium, actually didn't lose any bone mass at all. The bone mass remained static, both at the lumbar spine, and although it was reduced slightly, the placebos at the femur, this wasn't significant. So that really implies that if you give active vitamin D, if you give vitamin D and calcium, and perhaps have lower steroid use than was happening perhaps 10 or 12 years ago, then actually you may not need a bisphosphonate to have to prevent loss in bone mineral density. And what's striking about this paper, compared to perhaps some of the other bisphosphonate studies, was that steroid use was quite low, so less than 1,000 milligrams of steroid per patient. There was less rejection, which I guess probably ties in with steroid use as well. And the PTH at baseline was 5 times lower than in previous studies. Okay. Sorry, I didn't write that down in previous studies, but that should be PTH was 5 times lower than in sort of the early abandonate studies. So a more recent study, this is a very small study, 42 patients, live-related transplants, randomised to risedronate weekly or placebo. 29 of the patients got bone biopsies. There was a tendency to sort of reduce steroids so that everybody was on 5 milligrams of steroids prednisone at 3 months. And what you see here is that there was absolutely no loss in bone mineral density in either group. There was no impact of risedronate really on bone mineral density, and there was a suggestion that the bone loss was perhaps attenuated more in women and was greater in women than in men. And if you look at the repeat bone biopsy data, again this shows what we showed before, which is that in the control group, yes, some people with high turnover disease do improve, some people actually go with high turnover disease end up with low turnover bone disease, and some people have a mixed picture. So you do get an evolution of bone disease, but you don't necessarily get a complete improvement. And if you look at the impact of risedronate on bone histology, again, you see that you don't see so much high turnover bone disease, and obviously bisphosphonates will reduce bone turnover, so unsurprisingly, there are a few people here who are going down to a sort of lower turnover bone disease. But there's no discernible difference between risedronate and just control. And if you look at a kind of overview of different medications and therapies for bone disease post-transplantation, what you will see is that things like bisphosphonates can improve bone mineral density. Vitamin D receptor agonists may improve femoral neck and lumbar spine bone mineral density, perhaps some evidence for cinecalcet and parathyroidectomy. So you can have some positive data on BMD, you can have reasonable data, the evidence for its effect on BMD is quite strong, but in terms of whether this actually reduces bone fracture, you can see level 2 to 3 see evidence base, a much poorer evidence base. So we know that all these interventions can improve bone mineral density, so bisphosphonates, vitamin D receptor agonists, perhaps cinecalcet, but whether they actually improve fracture rate, we simply don't know. So I think the key thing here when managing bone disease is to individualise therapy. You need to develop your own protocols, audit the protocol depending on your own resources, access to densitometry, whether you have access to vitamin D assays, and then decide what to do. This is a very old algorithm, but I just put it there as an example of the type of thing you can do. So in this group they recommend doing DEXAs on people, measuring the PTH and vitamin D levels, as well as osteocalcin and alkaline phosphatase to have an idea of bone turnover. Then you risk assess them according to their sex, their age, their body mass index, and the PTH levels, whether they're diabetic and how much steroid they've had. And then once they've had a sort of risk number attached to them, you then look at the data and look at their T-scores, you look at whether they've got vertebral fracture or not, and then decide whether you're going to just give them vitamin D, calcitriol, that's in black, or whether you're going to try giving them a bisphosphonate. Clearly bisphosphonates and denosumab, which is an anti-rank-Leiden antibody that's also licensed for treatment of osteoporosis, they will reduce bone turnover, yeah? So they will inhibit osteoblastic and osteoclastic activity, so you have reduced bone turnover. So if you have adynamic bone disease, those drugs will worsen the adynamic bone disease, which is why if you're going to give them to people with advanced kidney disease, you really need to have access to a bone biopsy service. So just to conclude, what did I say? I think management of bone disease post-transplantation is difficult, but first of all you need to monitor the mineral abnormalities, correct them, and ensure the patient is vitamin D replete. KDIGO recommends doing a DEXA at baseline and at 1 and 2 years. That's predominantly opinion based. Whether you do a follow-up scan at 1 and 2 years is really a moot point, particularly if you've already determined the treatment plan on your baseline one. There are no established interventions that have been shown to reduce fracture rates post-transplantation, and that will be very difficult to show. If you think of the general population, the studies that have reduced fracture rate tended to be in the thousands, and obviously that's not going to be possible in the transplant population. Very important to realise that fracture rate reflects both bone mineral density but also bone quality, and it may explain partly why, first of all, the DEXA and the value of DEXA in terms of predicting fractures may be limited, but also may explain why the risk of fracture reduction with bisphosphonates is perhaps less in the transplant population than in the general population. Finally, both calcium and vitamin D bisphosphonates reduce bone mineral density post-transplantation, but the beneficial effects of bisphosphonates may be less in the current era of reduced steroid exposure, better PTH at the time of the operation, combined with giving vitamin D and calcium. And as I said already, there's evidence to demonstrate that improving bone mineral density translates into reduced fracture rates is variable. Thank you very much for your attention.